So it's my very great pleasure now to welcome to the podium Professor Peter Sly. Peter is a world-renowned respiratory physician, particularly paediatric physician and paediatric pulmonary problems, has an extensive research pedigree, has an NHMRC Senior Principal Research Fellowship, is director of many organisations and has WHO recognition and other slew of awards, which you can read on his bio. I won't rehearse all of those here, but it is another reminder of just the quality of research, clinical research, that we have in this city, Brisbane, which is actually a long legacy that we've had for a small country town at the far end of the world. It's astonishing how many really genuinely world-class researchers this little town has pushed out over the years, and Peter is one of those people. Peter's also a fellow of our academy, so it's my very great pleasure to welcome you to the podium now and let you give us your views on life as a clinician-scientist. Thank you.
Thanks, David. Yeah, so I'm emeritus paediatric respiratory physician. That means I don't see patients anymore because I'm too old. But also means I don't get paid by the Queensland government anymore. That's another one. So this is my thoughts. Things that I say here are, I guess, my opinion and my thoughts. They won't necessarily agree with what everybody thinks. But I'm also really happy if people want to interrupt and ask questions or say, no, look, I don't agree with that. So interaction is fine, or we can leave it to the end. I have slides. If we get through them, that's fine. If we stop part way, that's fine also. So I'm going to start off with my thoughts about what is a clinical scientist and why we actually need clinical scientists. Clinically trained individuals think differently. They think about the problems that they face differently. They are informed by the clinical world. And I'll say right here, when I'm talking about clinical people, I'm not talking about medical people. I'm talking about those who are involved in the healthcare of people. They may be nurses, they may be physiotherapists, dietitians, speech pathologists, whoever. But they are clinically orientated people. They think differently. And there's no single journey as to how you get into this. Some people, I'll also declare that I'm from the old times when we did medicine as an undergraduate degree. We spent the first 3 years of the learning the basics. And then we spent 3 years in hospitals learning the clinical stuff. And I personally still think that's the best way to do it. Nobody agrees, but I think it's different. So journeys now, some people will do PhDs before they do their clinical training, and that is fine. So there are many universities, including UQ, offering combined PhD, MD programs. They are tough. And they are tough because you've got two tough programs that compete with each other. And you've got to really look to see whether you're getting the time you need for each of those programs. Some will do PhD during advanced training, which is what I did. And some will do their PhD after their clinical training. Some do clinical training and never actually do clinical practice. They just go straight into research. And you might think that that could be a waste, but I disagree with that because I think there are plenty of examples of people who've done their clinical training, go into a basic or clinical science career, and they're influenced by their training and they make different decisions and think differently. So what is clinical research? To me, it's research directed to addressing clinical problems. And these problems often come from your daily experience in your work. And it's true, very much true, that clinical dogma, the things that are supposed to be known as facts, always need to be questioned. And what we knew in the 1990s, we now know is not true. And that's so the world evolves, evidence evolves, life evolves. So you always need to be thinking about, is this still the best way to do this particular treatment or to treat this particular condition? And it's usually, clinical research usually is an iterative process. You have a clinical question, and I'm going to show you some examples of this in a minute, that induces you to do some research. You get your results, you modify your clinical practice, and then things say, well, hang on, that hasn't solved the whole thing. What do we do now? And then, so this is an iterative process. It does keep us in business, but it's important. The other thing, which is an absolute must, clinical research has to be multidisciplinary. No clinician, I might say no scientist, but no clinician has all the skills they need to address the problems. You need skills from multiple areas, and particularly when you're talking about people and variations amongst people, stats are really important. They're often complex, and the best statistician in the world can't fix crap data. You need the statisticians involved at the beginning of your planning to make sure that you're collecting the appropriate data. And so collaboration is key to clinical science. I collaborate with people from many, many, many disciplines. I can part speak engineer, I can part speak psychology, I can part speak other things. But so you have to be able to collaborate with different people from different disciplines. So I'm going to give you a couple of examples, and I've heard people have been talking about how depressing, and we're wasting our time doing research. These examples actually work. So this is a problem from when I was in WA before I moved to Queensland. The clinical problem was we were getting inundated with admissions of young children with croup. WA, like Queensland's a big state, and you'd have to move kids from the regional areas to the capital city, and you needed to intubate them to do that safely. There was a clinical observation that kids who were given steroids could be, systemic corticosteroids, could be extubated more easily. And so the people in the emergency department in Perth looked at the evidence. There were inconclusive reviews and meta-analyses that really didn't help. So they started a clinical trial, a randomised clinical trial of a single dose of dexamethasone to kids fronting up to the emergency department with croup. And it showed in that first trial that the median duration of admission was reduced, and kids didn't end up as sick, and fewer of them went to ICU. That stemmed a lot of further research both in WA but also around the world, and it's now routine therapy. In fact, GPs give it. And so the problem is a lot less than it used to be. We have another problem where our wards in winter were clogged with infants with bronchiolitis on oxygen. They weren't really sick, they just needed supplemental oxygen. And we had for years been treating people young infants at home with oxygen when they were born prematurely and had chronic lung disease. And so one of the clever general paediatricians said, well, we're going to do a trial of this. And they set up to do a trial of home oxygen therapy for infants admitted with bronchiolitis. It shortened hospitalisation by 2 days, and only one child in that initial study required readmission. And again, that's now routine clinical practice in areas where there is support for home oxygen programs. One that hasn't quite worked, this one worked too. So we, in WA, we were the last state to introduce newborn screening for cystic fibrosis. And there were political reasons for that, but it gave us the opportunity to set up a surveillance program in the anticipation of newborn screening was coming. We convinced everybody, including the families, that we were going to do these routine assessments at diagnosis around about 3 months, then annually up to the age of 6. Under general anaesthetic, the kids would have CTs, bronchoalveolar lavage, lung function and look at biomarkers. And what we found during that surveillance program changed the way people manage cystic fibrosis. Previously, it had been pretty much a reactive treatment, so kids were treated once they had symptoms. We showed that these kids were developing progressive lung disease even when they were asymptomatic, that more than half of them had bronchiectasis, which is sort of damage of their airways on the CT by the time they went to school, even though they weren't particularly unwell. And we also found that we could predict this by looking at neutrophil, exaggerated neutrophilic inflammation and free neutrophil elastase activity in their lungs. So we set up and funded and did a 10-year RCT treating infants in Australia and New Zealand from 3 months to 3 years with azithromycin as a primary prevention of bronchiectasis, and it has been very successful. This was all in the days before the CFTR modulators, and that's changed the world a bit, quite a lot, but this is still was still a very important way to understand cystic fibrosis. And the one that hasn't worked, and it's still a problem, so all of these who want a problem for clinical research to solve, this is it. 40% of all preschoolers wheeze. And only a third of those will go on and have persistent asthma. We have not been able to come up with a way of determining which of those third of kids are, which means that all of these kids are treated with drugs that they can't, or lots of them can't respond to and have significant side effects. And so this is a problem out there. People have been working on this for decades, including me, and we still don't have an answer to this problem. I have a PhD student who's working on it at the moment. He probably won't come up with the answer either. So, how do you get into this game in the first place? First of all, you've got to think, what sort of research do you want to do? And again, there's no right answer here. You may be really invested in doing primary data collection, so going and collecting data from children or whoever. You may be content with doing analysis of data other people have collected, and I don't mean to say that in a negative way, because we all collect lots of data. We've got thousands and thousands of patient years of data sitting there waiting to be analysed. We're really good at collecting stuff. Getting it all analysed and put as output is a little bit more challenging. You may want to review the literature, and lots of people do. Systematic reviews, plus or minus meta-analyses, or you may be into computers and in silico modelling, particularly in pharmacology and other disciplines. You make some really good discoveries. The whole area of drug repurposing, using drugs for different purposes from which they were originally intended. The computer and silico modelling is really good at determining those sorts of things. But many aspects of a good research question, regardless of how you're going to do it, are pretty much the same. And we say to our PhD students in the first couple of meetings, you really have to sort of start small. The biggest part of my job as a PhD supervisor is narrowing the scope of what the candidates want to do. They want to do everything. They want to solve everything. And getting it down into a doable piece of work is a challenge. You also have to find a good mentor. We can't do this by ourselves. But not everybody is suitable as a mentor. A good mentor has got to be someone who's genuinely interested in helping other people, and particularly you. They need to be generous. They need to be generous with time, with ideas, and with resources. A good mentor is someone who will see their success through your eyes, not see you as a competitor. And unfortunately, that happens. And I guess good mentors advise rather than direct. The idea that you're working with someone, not working for someone. It sounds subtle distinctions, but you'll find that those things are really important. Okay, now you're ready to go. You want to work out what your research question is going to be. It needs to be clear and focused. You've got to be able to describe what it is you want to do to other people. It can't be too broad, or you're never going to do it. It can't be too narrow, or it's not worth doing. It's not to be either too easy to answer or too difficult to answer. Things that are easy to answer have already been done. Things that are too difficult to answer, things that haven't been answered, may be because it's not possible. So you need to be able to research it. And in my view, it needs to be analytic rather than descriptive. You can start that with description of a problem is part of it, but it's not the final thing. There are academic programs in clinical epidemiology. I'm not an epidemiologist, but I'm told that they like you to think about these PICO and finer criteria. So you need to be able to specify what the population you're going to be studying, what the intervention or exposure, what the comparison may be. It's not always possible, and what the outcome. The finer criteria that your research needs to be feasible. It needs to be interesting, because if it's not interesting, you're not going to finish it. You'll get bored. Novel, that's not always necessary or possible. In fact, repeating, examining whether somebody else's results are reproducible is a valuable component to science. You want to do it all the time, but there are some rules that it has to be ethical. And here, it's important to remember, particularly if you're dealing with people, that if the research program is not scientifically valid, it is by definition unethical, because you're not going to be able to get valid data out of a program which is not scientifically valid. And they use these things for, and this can be a useful way to start thinking about exposures where you've got an exposed group and an unexposed group and an outcome. You were laughing at my slides. Oh, okay. All right, there you go. And if you put this into something you can do, so you can look at exposure. I'm interested in impacts of maternal smoking during pregnancy, so you can have an exposed group and an unexposed group, and the outcome might be low lung function at birth and those who have low lung function and those who don't. And you look to see how this doesn't work all the time, and in fact in environmental epidemiology or environmental research, it is becoming increasingly difficult to have a non-exposed group. We're interested in the health effects of plasticizers, or what are now called the forever chemicals, the PFAS and PFOA. Everybody's exposed, everybody has a blood level, and so you're looking at variations within that. All right, so I'm going to go through what a research question that was done at the Children's Hospital here over the last few years. One of the trainees came to me and said, I have this idea, I want to look at this. And so that there was the question was how fluid management of infants admitted to the hospital with acute bronchiolitis was done. There were two main ways of doing this. You can give the kids continuous fluid through a nasogastric tube, or you can give them bolus fluids either through a nasogastric tube or through their mouth. And so the two different camps. One says it's dangerous to give fluids all the time through a tube because that decreases the ability to swallow, it decreases upper airway function and increases the risk of aspiration. The other says no, you're better off giving boluses of fluid, and people say, well, no, that's going to distend the stomach and make the risk of aspiration worse. So start off with a literature search and what's in the literature, what's known. Why choose one over the other? What are the alleged benefits? What are the alleged risks? Has there been a systematic review or Cochrane review being done? And if not, would one be helpful? And in fact, that's somewhere to start. So then, in clinical practice, look at a clinical audit. What's actually done? how often in our hospital that we're using continuous fluids versus bolus fluids. If you don't understand what I'm talking about, please say, and I'll explain. Why do clinicians choose one over the other? Is there a clinical guideline? We're obsessed with clinical guidelines in hospitals. If there's one, is it followed? And if it's not followed, why is it not followed? So and then sort of asking what aspects of this practice could be improved. And from those, looking at those sort of things, you then say, well, what's the research I'm going to do? So what is the study design? So the optimal design depends on the skills available, the facilities and the resources. A prospective observational study will provide evidence. It won't provide as much as a randomised clinical trial, but can you actually design a clinical trial without doing a pilot study first? Do you know what the effect size that you're supposed to be trying to determine is what you want to do feasible? And so sometimes you need to start with a smaller pilot study before you can develop a randomised clinical trial. And before you do any of that, you get to the statistician. And the statistician is going to help you understand the sources of potential bias. If your study design has systematic bias in it, you cannot correct for that in any analysis. Sometimes it's unavoidable, but you've at least got to know about it and try and mitigate against it. The statistician will help you understand what the effect size that you need to be looking at. So in a clinical problem, there's a couple of ways of doing this. You can say, if I was able to get children discharged a day earlier, is that a clinically significant, big enough effect to warrant the study? Most people would probably say 24 hours earlier out of hospital is. There's a fair bit of cost in that. But if it was an hour earlier, it probably isn't. So you need to think about these things. And having gone through that, do you need to revise your research question from what you thought you were originally going to do? Then you undertake the research and you get your successful outcome. This trial went over about 18 months of the Children's Hospital and it was published. It showed that there was no advantage of bolus versus continuous feeds, so that it was really then which was more practical and implementable in the particular hospital. And in fact, now more kids are treated with bolus feeding rather than continuous nasogastric feeding. So, to sum up, clinical research is research addressing a clinical problem, in my view. Clinicians think differently from other scientists, but they don't have all the skills. A good mentor and collaborations are absolutely essential for success. And you need to decide what type of research you want to undertake and start simple. I can't say strongly enough you need to consult a statistician early in the study design stage. And the reason we do it is that clinical research can be extremely rewarding. I've been in this game for over 40 years now, and my wife says, when are you retiring? And I said, well, I haven't finished things yet. And that's a bit of a bone of contention, but anyway, thank you for your attention. If you've got some questions.
Fantastic. There you go, a primer on how you go about clinical research. So do we have questions from folks in the audience at all? Where have we got one up there? There we are, yep.
My name's Priscilla. I'm a nurse.
It's all right, you can do research too.
And as a very novice clinical researcher, one of the biggest problems we experience in the clinical field is research takes such a long time to be trusted and taken up in the clinical arena. So one of the issues is intravenous access or cannulation. And a really big study was done on 3-day replacement of cannulas versus when necessary. And the evidence showed there was no difference in infection rates or complications. But yet to this day, across all organizations, we still change cannulas every 3 days.
Not in paediatrics.
That's because they're difficult intravenous access. They're divas.
Yeah. That is
And nobody can get them in. But how do we get people to change?
By quoting the evidence. My very first publication came from a ward round when I was in my second year, first year of paediatrics, and the boss made some pronouncement about what eosinophils in sputum indicated in children with cystic fibrosis. And he said, when we see this is the thing. I said to him, I'm not sure that's true. And he said, well, how do you know? I said, I've been measuring it. He said, why? He said, because you asked me to. And so he said to the fellow, have a look and see what he's got and see if there's anything in it. And so and with that test was never ordered again in the Children's Hospital in Melbourne. It's through sticking to the evidence, and when someone says we need to change this every 3 days, you say, no, you don't. Have you asked the patient, what do they want? Do they want their cannula changed just because it's been policy, or are they happy to follow the research that says there's no need to? And I guarantee, now I do understand the hierarchies, and I do understand the pomposity of consultants, particularly surgeons, that won't necessarily listen to what junior people have to say, but it really just has to be pushed through. In the hospitals now you have quality improvement and quality audits and all those sorts of things, so you've got to push it through those mechanisms. I know it's not trivial.
This harks back to the point you made, Paul, about Dave Sackett's evidence trolley going around on the ward round saying, what's the evidence? What do we know? So it resonates. I think Jason's got a question here.
Peter, my question relates to your comment about clinical practice guidelines. And the irony of it, if you look at clinical practice guidelines, almost all of them are underpinned by low quality evidence, if not just expert opinion. And I think that they're a wonderful source of ideas for research directions for people to solve those. I was wondering if you had any comments on that, and if someone was to come to you and say, I'd like to study this broad area, how you then distill it down into a potential topic, which is feasible.
Yep. I agree completely with your comments about clinical guidelines. I was sat on many a panel where we have pontificated and come up with clinical guidelines, and one of the things about things that are designed by panels or committees is nobody ever agrees with them, including the people on the panel, because they all have to come to a consensus. I think the idea is to some areas that I know. So asthma clinical guidelines and treatment of asthma in children in the emergency departments. The amount of evidence that that's based on is very small. So if someone wants to come, a trainee wanted to come and say, well, okay, let's examine where did the 3 doses of salbutamol 20 minutes apart over the first hour come from? And there were some studies done in the 1980s and haven't been revisited. They were done with, and now we've got different drugs, they're delivered different ways. Is that still the right way to do it? And so I think that by asking questions, how good is the evidence underlying this statement in the clinical guideline, this dogma on a ward round, is the way to address some of these issues. But I do take the point, proving something doesn't need to be done is not the same as automatically having it implemented in the hospital. But grand rounds and other things in the hospital, there are fora for those things.
And indeed, implementation science is actually a new field of how you take a fact and turn it into practice. It's
I recently learnt about the health beliefs model. My background in sciences is physiology. But as I said, we've collaborated with many people. I learned about the health beliefs model, and so I had a PhD student doing some research in Vietnam, and they were very much into this. And the health beliefs model is a way of understanding why people don't adopt health protective behaviours. So we know that smoking's bad for you, but some people still do it. Why do they still do it? And to understand, you're not going to change behaviour unless you understand the drivers and the barriers to that change. And the same could be, that's what the implementation science in changing things in clinical practice is, I think, supposed to be doing.
Now, we would have time for one quick question. If anyone has a question, there's one over here. There's a microphone on its way down to you, so...
Hi, so going off what you were just talking about, I'm wondering where you see kind of consumer engagement in research going, not from the perspective of clinicians, but from the patients themselves.
Yes, that's very important, and I have grown up in the era where that wasn't really considered. But we are engaged in that now. So where I see that is that we have lots and lots of things that we can do. But what we want to understand is what's important to patients. Now, as a respiratory physician, I've spent a long time with people with chronic disease, with cystic fibrosis, with asthma and other respiratory diseases. We can come and tell people this is what we think should be done. But what's happening now is that the patient groups, particularly through the organisations, through the Cystic Fibrosis Foundation and others, that they do surveys of parents, say, what are the things what are the biggest problems for you? What are the things that you would like research to solve most? Sometimes they align with what we think, but not always. And so I think that it's important to understand what your, if you like to use another word that wasn't there when I grew up, stakeholders want you to achieve. Because if your research matches with their priorities, they're going to get engaged in it better. They're going to implement it better, at least we think they will. And so it is something that I think it's really important. It's not just a box you've got to fill, or 3 pages now. You've got to fill out an MRFF application or an ideas grant. It's actually important to divide it. It's not trivial, but where there are patient groups and patient support groups through foundations, engaging them and getting them to ask the questions, most of them have already, it does help.
Thank you. Well, we better close it up now. So, Peter, thank you again for your presentation. Thank you for telling us how you became a clinician scientist and what your journey involved.